A warm welcome to all of you to this workshop today. My name is Jordi Llinares. I'm the head of the therapeutic evaluation groups here at the agency. I've been working before with orphan diseases for a long time here at the agency. And I'd like to really say thanks to all of you for being here and to welcome you. It's an extremely interesting agenda that we have today before us. And let me say some words apart from the welcoming. I think this week would be very difficult for me to speak without any reference to the, I would say, political environment. And I'm not going to give you any political speech, but I think that this workshop defies really what is behind the current situation about isolationism, about finding gaps between people, and this rhetoric against establishment and institutions. I think that what we are doing today is totally the contrary. We're here to really talk about patient needs, to talk about how we can develop products to address the patient needs. We are here really to build bridges between those issues. So we as regulators need very solid bridges because we need to take decisions on marketing authorizations to really open the door for those treatments to reach patients at the end, after, of course, other assessments happen. And for that, we need solid data, strong science. And that is what we want to do here today, to start discussing these issues for this very difficult situation, SMA. And I think that's also brings me to another comment about the situation outside, is that this meeting started with a very informal conversation in Edinburgh in the conference on rare diseases, the European Conference on Rare Diseases. And this also shows how the agency is open to listen. And that's also what I think we need to have, open minds, listening mode, so we really can address the needs for the patients. And from that small conversation, we said, yeah, please send us a letter. We'll explore if we can have a meeting and look around today. I mean, it's an extremely good panel of speakers, extremely knowledge audience. And I think from there we will have some progress, which is what we want to have for patients in Europe. So that would be everything I want to say. So again, welcome. And let's have a very fruitful meeting and then actions to implement after the meeting, which is also what is important for us. So I give the floor to Serge Braun for an introduction. Thank you.
Thank you very much. First of all, I would like to, in the name of the SMA community, to thank EMA for co-organizing and hosting this spinal muscular atrophy stakeholder workshop, also organized by SMA Europe and TreatMD. I'm representing the French Muscular Dystrophy Association, AFM-Telethon, which supports research and care for all neuromuscular diseases and many other rare diseases. But more importantly, I am part of a genuine community of patients, researchers, clinicians, and industrial partners involved in the battle against a very serious disease which has remained for so long an orphan of any potential treatment. The present meeting comes at a turning point. Following the discovery of the gene, the causative gene in 1995, and a decade of research on pathophysiological mechanisms, new innovative therapies have now emerged and are now applying for a regulatory approval. A number of issues will be discussed today, which are representative of the whole field of neuromuscular diseases. We are dealing with a very severe, crippling, and potentially fatal disease, which strikes spinal cord motor neurons. Actually, it's 100% fatal in SMA type 1 in childhood, and it has significant impact on survival in SMA type 2. Today's meeting is a sort of moment of history for SMA, very similar to what we experienced several years ago with Duchenne muscular dystrophy. It's a crucial meeting, I think, for all of us. It's part of a very welcome mutual education process. I'm saying mutual education process. Each stakeholder has valuable experience and knowledge to share and to learn. We all understand that the path to the drug is a very delicate and long, complex process that aggregates technical, scientific, medical, and ethical issues, but also specificities, which are directly related to this severe fatal neuromuscular disease. Specificities which deserve special attention. We must keep in mind that the clock is ticking too quickly for families. After 20 years of discoveries and innovations, new drug candidates are now available to slow down and potentially reverse some aspects of the disease. Today we will discuss progress that we have made as a field in standardizing care and its impact on survival and function. We'll discuss therapy and outcome measure developments, as well as parents and patient perspectives on the impact of SMA and on clinical benefit and expectations. We all hope that by the end of the today meeting, every stakeholder will have a complete view on all the issues of SMA drug development and how best to anticipate and to overcome them for the sake of the patients. So thank you very much for being here, and we are looking forward to a very fruitful workshop. Thank you.
Good morning. May I just briefly introduce myself? I'm Thomas Voigt. I'm a professor at University College in London here and director of the Biomedical Research Center at the Great Ormond Street Hospital. And I have the pleasure of chairing this first session together with Manuel Haas, who will also introduce himself briefly.
Good morning, and a very warm welcome from myself. You were expecting to see Professor Braun as a co-chair of this session, and he asked me to send his apologies. Unfortunately, he's no longer available to join us today. But it is my pleasure to step in and co-chair this session with Professor Voigt. Thank you.
Okay, so we will go right into the sessions. I would like to ask all speakers to stick to time. We have not necessarily question and answer sessions afterwards, but if we have enough time, 1 or 2 questions can be taken. And we will start right off with Mencia de Lemos, who will tell us about the parent perspective impact of SMA. Please, when you speak, put your microphone on. When you stop speaking, in the end, put it off, because the webcam follows the microphone. Mencia, please.
So, hello everybody. I'm here today, as everybody else, to speak about spinal muscular atrophy, SMA. I have direct experience on the disease because I have 2 children that are affected with SMA type 2. One of them, my youngest one, is over there in the picture. He's 6, and my older daughter is 8 years old. And I'd like to start my speech by introducing you to the disease the way my husband and I were introduced at the moment of our diagnosis. So the symptoms of my daughter didn't seem terrifying. She just wouldn't let go of my hand when she was walking, and we thought that she might need some special boots for some time. But apparently we were facing a devastating disease that had no treatment, that has no cure, and that progressively is going to get rid of all her strength and all her capacity of moving. So her legs would be affected. That means that she would lose the ability she had to stand assisted. She would also stop crawling. She'd stop moving completely her legs. Then her arms would also be affected, and this would get away from her capacity to write, to comb her hair, to wash herself, to feed herself. And so she would also lose the capacity to use a keyboard or the joystick of her wheelchair. Her trunk would also be affected, and it will be very hard for her to hold her spine up. So it will eventually collapse, if we're lucky, after she's 10 years old, but she'll need most probably major surgery. And because of the trunk weakness, also her respiratory capacity would be affected. This means that a simple cough can lead to a fatal pneumonia, that a phlegm can make her choke because she doesn't have enough strength as to cough it off. And she would need, as she does, non-invasive ventilation, for the moment only at night time, to be able to prevent as much as possible chest deformities. Her neck would also be affected, so she wouldn't be able to hold her head right. And in brief, it was quite a terrifying prognosis, and what's worst of all, well, first that our son was also affected, but then that this prognosis is happening, as we were told, step by step. And we're struggling every single day to slow it out, but the disease is there. If we're lucky, with enough cares and luck, she will reach adulthood, but even in this best case scenario, she's going to be severely disabled for life, and she's going to be completely dependent for everyday life. So how bad this diagnosis might sound, we were still happy because it was not of an SMA type 1. If that had been the case, that would have meant that our daughter wouldn't have had never the ability, of course, to stand nor to sit. She would have struggled to feed herself and to breathe since very early stages, and she would not be with us probably after 1 year, maximum 2. So that's SMA. And now I want to speak about what it means to live with SMA. So I was saying, and I stress it, it's progressive. SMA has no cure, and it has no treatment. And no matter how much effort you put into it, and you can put a lot of effort, you can only try to improve a bit the quality of life. You can try to slower the next milestone from coming, but the disease is so strong. And there are also other contextual facts that don't help you at all, such as, for instance, cold weather that can lead you to have chest infections and maybe pneumonia. You can struggle to gain weight. You might struggle to lose weight, and then you're too heavy to move. Fracture in a bone. All of this just complicates things so much, and it makes you go one step further down. And you know that that's a no return way. So it's quite terrifying. As I say, if you want to try to slow that down the deterioration process, you need enormous effort. So all this effort, it's not going to pay you back that much. So it does give a kind of helplessness feeling, frustration feeling that frequently leads, as the patients get older, to stop taking care about themselves. Given that their life is complicated, they have little time, and they don't know for how long they're going to have this time, they may as well try to enjoy and not go to hospital visits, not do the physical therapy, respiratory therapy, what for? But I haven't said yet that one thing that SMA has, and surprises everybody, is that minds are so beautifully preserved. People with SMA are so bright. They're so willing to live the life as everybody else and enjoy, and they're just trapped on their bodies that are not working. So to give you just an example, for children to participate on school activities, well, they're bright, so why not, like at the classroom, keeping up with their classmates? But then they start writing and they fatigue after writing 2-3 words. Then they have to do their hospital visits, the very minimum once a month when you're healthy. You have to interrupt to do physical therapy. If you want to stand 2 hours on the standing frame as you're told, you have to find the time somewhere. If you have a cold, you have to be very careful, maybe not to go to school. And in the playground, this is even worse. You can't kick a ball. You can't catch a ball. You can't hide. You can't pick a stone from the floor. And it's frequent that you can't even speak loud enough so that your friends hear you. So how are you going to interact? It's complicated. It's not impossible, though, but it's complicated. And that's for young adults. It's also complicated to live with the fact that your peers are gaining independency, they're getting their driving licenses, they're just taking a backpack and traveling around the world, and at the same time you're losing capacity and you're becoming more and more dependent. It's not that you can't do anything, it's just that everything is so much more time-consuming, effort-consuming, you need planning, and it's so costly. Everything, keeping up with your studies, finding a job, finding a boyfriend or a girlfriend, keeping up with friends, it's complicated. This is as for the patients, but for the caregivers, life is not very easy anyway. First of all, you have the psychological burden of living every day with your child and trying to teach him how to live a happy life when you're confronting to a need of readaptation to the worse all the time, and not knowing when the fatal moment is going to come. So keeping up spirits it can be very complicated. For a parent of a type 1 child, it's close to impossible to give their children or themselves a normal life. It's 24/7 cares, it's hospitalizations, it's confrontation to very complicated decisions, and then the certainty that you have little time left with your child. For a type 2, making the life of your child as normal as possible is huge. So I'm just going to give a very easy example, which is what I do every day. So I get up and I only say it with one child, but it's times 2. I get up, I take my child out of bed and I put her on the toilet. I help her to get toileted, dressed, I do the stretchings with her, and then I help her to the wheelchair. We go to breakfast, and I help her with breakfast. Then we go to the car with the ramps, everything. We go to school. And then I normally have to take her from school to do some of her therapies, whatever. Swimming pool as much as I can, I've been told. We do it twice a week. Standing frame 2 hours a day. Back home, respiratory therapy, stretchings again. Then shower, dinner, homework. She can't stretch to get a pencil, so you have to help. And then finally she goes to bed. And you go to bed, but you don't sleep because she needs help to turn at night. So you have to wake up several times and turn her at night. And then she uses a non-invasive ventilation machine, which the alarms set out. Maybe 2 times, if you're lucky, 3 times a night, maybe 8 times a night. You have to get up, you have to sort out what the problem is and get back to bed. So it is burdensome, I think. And the burden is not going to decrease. On the contrary, my child is going to grow, she's going to be heavier, and she's going to lose abilities. And the economic burden is enormous. It's enormous. People with SMA are trapped on bodies that don't work properly. So you're talking about technology. You're talking about powered wheelchairs, manual wheelchair if you're lucky and strong enough, car adaptation, house adaptation, bathroom adaptation, and normally one parent is going to have to quit their job, so one less income. It complicates things a lot. And to add on top of all of this, SMA is a rare disease, so it's very likely that the doctor that treats your daughter or your son is the first patient that has with SMA. So this can be challenging. It can be life-threatening if wrong decisions are taken on an emergency, but it can also hinder quality of life if wrong decisions are taken at the wrong moments. And now I'm going to speak about what it means for us to be confronted to a situation in which stabilization or even improvement could be possible. So First, I have to say that this means putting hope in the scenario. We learn to live without hope. We learn to live our lives not thinking too much about the future, just carrying on swimming. And suddenly you have hope, and you have to learn to digest it. It's great, but you need your time. And in general, expectations of young patients and their families are more on the recovery side, or not reaching the next milestone that you've been told that you're going to reach, so wheelchair dependency, hospitalizations, etc. For older patients, the hopes are more on stabilization and on not losing those little abilities that you have left, but that you're gripping to them to be at least a little bit dependent on some actions. The way I understand it, a stabilization is great, and it would have a leverage effect. First of all, you would want to take care of yourself if your efforts are going to pay back. So you might as well restart your physical therapy, your hospital visits. But also, if you have less chest infections, it's probable that your respiratory capacity is not going to deteriorate as fast. And then sometimes I think that an apparent stabilization could be hiding an improvement. If you're maintaining your functions and you're growing and you're taller and you're bigger, that looks as an improvement for me. Then the fact of looking at the future and knowing that you're going to be able to do what you're doing today, honestly, I think that parents can understand me, is enormous, enormous to be able to plan and say, in 10 years' time, I will still be able to drive with my chair around the world. It's awesome. And then stopping and lowering the clock could be so good because you have time, first of all, and then you have more opportunities to find therapies that could help you. So, of course, if we talk about improvement, for us, it's just awesome. Any minor improvement. People with SMA are so conscious of their body, of their strength, and of their capacities that they really take the most of every bit of energy. Any bit of improvement would have an impact. As for clinical trials, I'd like to say that the families we are confronted to fears and hopes. The individual decision that's attached to enrolling your child or yourself in a clinical trial is really linked to buying time. You want to access to a drug as soon as possible if it can work. So the biggest fear attached to the decision is, will I fall on the placebo branch? If you're a type 1 parent, that means, I compare it to playing a Russian roulette, honestly. If you're on the placebo branch, you're very likely not to reach the drug, even if it's efficacious. For a type 2 child, it might mean that the time you spend during the trial, you're losing in an irreversible way functions. So our second biggest fear is the duration of the trial. The longer it is, the more functions I'm going to lose. And then if we are in an environment that you could choose between different options, there is a fear of choosing the wrong option. What if I am testing the drug that's not going to work or is not going to work to my child? How long must I keep up with my commitment and then wash it out and then try to go for something else? It's complicated. And of course, security and the secondary effects are scary for us. But I tell you, SMA is very real and very scary. It's not potential. So I do think that to some extent, we would have to balance that and be able to decide whether we want to assume certain risks or not. And then finally, after the clinical trial, the access to the drug, I would say that the main fear is that the drug is accessible with a label that's broad enough for everyone that can have a minimal benefit, can benefit from it. So I'll just summarize the main points of what I've just said. SMA takes away from you everything. It takes your life away from you. It takes your strength. It takes your abilities. It takes your family away from you and from the life that you had planned. In a way, it's in such a tough way. Can you imagine what it is just noticing that your child has lost another function? He can't hold a cup away up to his mouth. It's complicated. it is important for me to share that the stabilization or improvement is important for every one of the SMA community. And that the fears attached to participation in a trial are related to getting the drug too late, therefore placebo, duration of the trial. And then the fears attached to access to the drug is that everybody has their opportunity. Thank you very much.
Thank you very much, Mencia. I think this was a very touching but also very realistic report of experience. Many of us, of course, are intimately aware that this is the truth. And I think you also touched quite rightly on some of the philosophical points, both regarding life and regarding choices with trials and potential new therapeutic drugs we are all faced with. Sitting on different sides of the table, of course, but we are all faced with this scenario. And I think we're very conscious of it. Thank you very much.
I would like to join Professor Voigt in thanking you very much, Mencia, for this excellent, actually, and insightful talk that you gave us. In my opinion, there could not be a better start for our discussion today, as in fact, who better than the patients and their families can talk about their disease? Who better than them can tell us about their expectations about the medicines? And who better than them can make the case for their engagement, for having a role to play in the development of those medicines and their review? So thank you very much again. It is now my pleasure to introduce our next speaker, Professor Wirth, from the Institute of Genetics in Köln. And Professor Wirth is going to tell us about the molecular mechanism of the disease, but also some words about its prevalence, diagnosis, and the classification of subjects. Dr. Wirth, yes, this is all yours now. Thank you very much.
Well, thank you very much for being here. And as a human geneticist, and since we are dealing here with the genetic disorders, I'm going to talk about what is the genetics of spinal muscular atrophy, the incidence, prevalence of this disorder. So to put you all on the same page, we're going to talk today about the autosomal recessive spinal muscular atrophy. But there are various forms of SMA which are inherited in dominant X-linked forms. We are not going to talk about this because SMA, the one which we are going to talk, it is the most prevalent. It makes 80 to 90% of all the SMA patients. Not that the others are not important, but this is what we're going to talk today. So SMA 1, 2, 3, and 4 all have the same start. The motor neurons are degenerated, and this leads to a symmetrical weakness of proximal voluntary muscles. Usually legs are more affected than arms. Later also the trunk can be affected. And very often, particularly the type 1 SMA patients, they have respiratory insufficiency, and that's also the reason why they're dying. So SMA, as I just mentioned, it is extremely variable. We have 4 different phenotypes. The type 1 is the most severe one, which starts usually in the first 6 months of life. And these patients, they will never be able to sit or to walk, and most of them, they're dying before the age of 2. The type 2, or the intermediate form, is usually starting after the first 6 months of life. Depending on the respiratory problems they have, the survival can be to adulthood, even to 40, 50 years. This is still possible. And these patients are able to sit, but they will be never able to walk. The intermediate, or the mild form, it starts after the first 18 months of life. The life expectancy is not really reduced, and these patients will be able to sit and to walk. And then we have a very rare form, the adult form, the type 4 SMA, which makes probably less than 1%. And in this case, the patients, they are very mildly affected. It starts usually after 13 years of age, and the life expectancy is not really reduced. So just for completeness, I put this slide here on for all those to be aware that we have very, very rare cases where you can see families with individuals who are marked here in gray, who have siblings who are affected, but the one in gray, they're all asymptomatic, and they have absolutely the same genetic mutations, the same genetic status as the affected one. They are protected by other modifier genes, and I think Arthur Burgess is going to talk a little bit about that. However, it's less than 1%, so we are not really aware for the therapies, I think, about this one. So, unfortunately, the majority of patients have the most severe form. It is more than 50% of all patients have the type 1, about 30% have the type 2, 90% type 3, 1% type 4. So we are talking here about one of the most frequent autosomal recessive disorders in human. And in Europe, in fact, we have one of the most highest prevalence. And this is based on carrier testing, on direct carrier testing by molecular genetic means. So in Europe, the prevalence is 1 in 35. It is a little bit less in the Asian population, where it is 1 in 56, sorry. In the African population, 1 in 91. In the South American population, 1 in 125. So at least for Europe, if you count now that the carrier frequency is 1 in 35, you have an incidence of around 1 in 5,000. And based on this incidence, you can more or less calculate the prevalence, which goes between, or it will be probably something like 21 to 25,000 people in Europe. About 40% of them are more than 90 years old. So now I'm going to tell you about the genetics of this disease, because all the therapies are mainly based on our knowledge which we gained on the genetics. So the gene which is defective, which is causing SMA, is the survival motor neuron 1 gene, SMN1. Now, interestingly, this gene has a copy gene, the SMN2, and this is something which evolutionarily occurred only recently. So we humans, we are the only one, single species, who has SMN1 and SMN2. Now, the two genes, they are extremely, extremely similar, and there are only very few base pairs by which the two genes can be distinguished. Most importantly is the one which you can see there in exon 7, the C to T transition. The C to T transition is therefore so important because it is localized in a so-called exonic splicing enhancer. So it recruits various important splicing factor. However, we have a second exonic splicing enhancer there, and there we have a recruitment of other splicing factors which were important. And all this take care so that each intron and exon is properly recognized and spliced out, the introns, so that the transcripts which were produced, they're always full-length transcripts, which produce a protein which is correct and 200% full-length. Now, in SMN2, this C to T transition, not only that it disturbs the exonic splicing enhancer, but it even creates a new silencer that recruits other splicing factors. And then we have, very importantly, because on that is based the Antisense therapy study mainly, we have in the intron 7 another intronic splice silencer which recruits also some splice factors, and this leads to an exon skipping. So in the majority of mRNAs, of RNAs which were produced, the exon 7 is not present, and this leads then to a protein which is unstable and degraded. Now, fortunately, SMN2 has still that little bit of the other exon enhancer, and this recruits these splice factors, which produce about 10% of correctly spliced transcripts. And the protein which is produced is absolutely identical to the SMN1. So to conclude here, most importantly is this exon 7. And this is always present in the SMN1, but unfortunately only present in about 10% of the SMN2. But this is very important. And so, something went wrong here. I get to that mouse somehow. Okay, I think now it should work. Okay. Now, most importantly, if we look to SMA patients, equally, whether they have type 1, 2, or 3, they show more or less the same homozygous absence of exon 7 and 8 or only of 7. And this is very important because we are dealing here with a disorder which can be extremely easily and reliably tested. Only very few individuals have other mutations, about 3 to 4%. Now, to understand what is really the reason why we have even then different phenotypes, this is based on the copy number of SMN2. So as you can see here, type 1 SMA patients, the majority have 2 copies. In type 2, the majority have 3 copies. In type 3, the majority have 4 copies. In type 4, the majority have 4 to 6 copies. So you have to keep in mind every single copy is producing more or less 10%. The more I have, the better it is. So here is just to keep also in mind that this correlation is not absolute, and we have to bear that really in mind. It is a good prediction. It has a good prediction value, but it is not absolute. So for everybody to understand why we even have more than 2 copies, because we have only 2 chromosomes 5. So on each chromosome 5, we have a SMN1 and an SMN2. So in SMA type 1 patients, the SMN1 is gone, it's deleted, and this leads then to only, these individuals are left with 2 copies, and this leads to type 1 SMA. Now, on the other extreme, the SMN1 is converted into SMN2. So it's like you would overwrite a file with another one. So therefore, these individuals have then 4 copies, and this leads to a mild phenotype. Now, when this happens on one chromosome and the other one a deletion, then you have 3 copies, and this would lead to the intermediate phenotype. So we can conclude that the SMN1 is the disease-causing gene, while the SMN2 is the main modifier of the disease. So what do we know about the protein? The protein is extremely important. It's essential for splicing per se. In fact, it has not only in splicing, but it has been correlated to many other very important cellular processes. It is expressed in the nucleus, in the cytoplasm. I'm not going to go too much into because Francesco Muntoni is going to speak a little bit more about this. So when this protein, which is in fact the ubiquitously expressed protein, is not sufficiently present, particularly in motor neurons, these are going to be mainly affected. And the neuromuscular junctions is the biggest synapse in our body between the muscle and the neuron. And this is mainly affected in SMA patients. So interestingly, since it is an ubiquitously expressed protein, we have to be aware, at least in animal models, we do see a lot of different other problems, and we have to be aware about this phenomenon, maybe also in type 1 SMA patients, when we are going not to give this drug systemically. But finally, just to hand over to the talk of Francesco, I want to remind you once more the basis for the Antisense oligotherapy study. So we have in intron 7, we have this ISSN1, this intron splice silencer, to which it's recruited this RMPA1. And the antisense oligos, they are blocking this intronic splice silencer so that more of the exon 7 can be integrated. This leads to a very nice upregulation of the full-length transcripts. Very importantly, these are rather very stable, so up to 6 months, we still do see much more of the full-length transcript. And when this has been used in preclinical studies in mice, the mice who normally live only 10 days, they survived more than 240 days with a pre-symptomatic treatment with a single or twice dose. So with that, I'd like to thank and give over to Francesco. Thank you.
Can you switch it off for a second? So thank you very much, Brunhilde. This was a good overview of the genetics. The next talk will be by Professor Francesco Muntoni, who is a professor at University College London, head of the Developmental Neuroscience Program at the Institute of Child Health and head of the Dubowitz Neuromuscular Center. And Francesco will give us a general overview of novel experimental therapeutic approaches. Francesco, please.
Thank you. Good morning. Thank you for the introduction. So that leaves me 2 seconds to thank EMA, because having been involved before in similar meeting and having had the privilege of having a dialogue and a lot of useful information, I really like the remark of bridges to try to understand each other well and try to do a better job for the future. Certainly, I did a better job having been involved in previous work with EMA in the past. So thank you again for allowing us to be here. As you expect from a clinical academic involved in clinical trials, I am involved as a principal investigator in a number of trials that I mentioned above, and I occasionally provide consulting advice to the companies that I mentioned on the right-hand side for the therapeutic development of these drugs, and I'm a member of the Pfizer Rare Disease Scientific Advisory Board for the last few years. This presentation will be relatively high level, but it's just to put things in context. And I will be discussing, again, extending a little what you heard from the previous speaker, issues related to protein localization and the role of SMN protein. And I will then give an overview of ideas that have been now translated into clinical trial. I will not give an overview of every single potential therapeutic preclinical development, but I will concentrate on what is currently in clinical trial. And really, what are the main areas where there is activity is increasing SMN protein level and dealing with secondary consequences. The SMN protein is a protein that is present, is ubiquitously expressed, is localized in the nucleus in this structure called GEMs, but is also in the cytoplasm. The GEMs are really powerhouse where splicing takes place, and therefore SMN is a plausible role in RNA regulation. However, it's not only in GEMs and the cytoplasm of the cells. For example, in dendrites and axon, is clearly present there and associated with specific cytoskeletal structures. In terms of what it does, again, this is just to give us overview of what SMN does. It's clearly SMN has multiple functions. It is part of a group of proteins involved in the GEMs in organizing splicing. And this is, again, for a pediatric neurology like me, a very complicated area. There are multiple spliceosomal complex. Some of these spliceosomal complex, and SMN is part of different of these complexes. Some of these spliceosomal complex are involved in generic splicing regulation, and there is a subtle but generalized splicing abnormality that can be demonstrated in SMA. But more specifically, a bigger role appears to be a role in one of these particular subcomplexes, where a splicing of a rare type of introns take place. So there appears to be a more genetic role in splicing and a more specific role in a subset of neurons, a subset of a transcript. But in addition, this is stuck, no? There is a role also in the axons in terms of translation and transport of messenger RNA. I think that you heard also from Brunhilde, the condition is certainly a motor neuron disease, is what we call a cell-autonomous motor neuron condition. You do need, especially if you want to put SMN back, you do need to put SMN back in motor neurons. There is, however, some evidence that having SMN also in other structure may help. The extent of this is clear in preclinical model. Of course, we will not know in the human very easily. There are other neuronal circuitries, for example, in glial cells, that appear to, if in the preclinical model, they give an advantage if SMN is there as well, in addition to the motor neurons. And there may be a role of other peripheral mechanisms. But I think the overwhelming priority is to put SMN in the motor neuron. So what are the therapeutic targets for spinal muscular atrophy today? This is a simplified version of one that was given in this very session a few years ago, where, however, there was really what was happening also in preclinical models. This is what happens in the more advanced clinical trials now on replacement SMN1 by viral gene therapy, the one that is on the top, affecting the splicing of SMN2, that is the residual SMN2, and convince this gene to include exon 7. This can be done by antisense oligonucleotides, but also small molecule that affect splicing. You can have an approach that is independent of the SMN protein directly, and this work to protect motor neurons that lack SMN or don't have enough SMN with neuroprotective factors, but also work on the endpoint problem that is muscle weakness with drugs that improve muscle trophism. I would just say this, that the field, again, as in Duchenne, the animal models have helped a lot the preclinical development. Spinal muscular atrophy has been helped a lot by models that have been made also by colleagues here in the audience. And I have to say that it's pleasing to see that some of the work that has been done in the preclinical model is now translating also with efficacy in the clinical trial. The animal models may not be perfect. They have a relatively severe disease, the majority of them, and a shortened lifespan, and the majority of them, or the optimal therapeutic response is if you intervene when the animals are pre-symptomatic, although there have been more recent tricks to induce more chronic disease that are helping to better understand the therapeutic window of response. So in terms of how you can increase SMN protein level, this was the first part of my presentation. Again, as I said, you can do by small molecule, antisense, and viral gene therapy. And you have seen before this slide from Brunhilde that I do not need to repeat, but basically you want more of the full-length protein, and whether you put it back by viral gene therapy or by antisense or small molecule that affect the splicing, the end result is more SMN protein. One word on antisense oligonucleotides. Firstly, already Brunhilde has indicated there are different types of chemistries. One is in clinical trial, and this particular antisense target a splicing silencer area. And these antisense do not cross the blood-brain barrier. This is an important consideration because it has got a lot of practical aspects. They need to be administered via repeated lumbar puncture in children and individuals with spinal muscular atrophy. The one disadvantage of having to give it via lumbar puncture also turns into a potential if you like, advantage that the antisense oligonucleotide does not leak out into the periphery and has a very long half-life in the central nervous system of approximately 6 months. And I'm not going to go into details of outcome of the clinical trials, but I just want to give the sense that clinical trials sponsored by the companies that I indicated at the bottom of this slide have performed a very comprehensive group of study from phase 1 to phase 2 to large randomized placebo-controlled trials in type 2 spinal muscular atrophy and type 1 spinal muscular atrophy. And as you are aware, the outcome of several of these studies has been announced very, very recently. Now, you can achieve splicing modification not just with the antisense oligonucleotide, but remarkably, there are two if for people interested in science, this is remarkable. There have been two companies and two group of scientists that followed a similar line of thought, although the path that they follow is slightly different. And they have identified in this particular study that was published last year, they have identified a group of restricted group of drugs that affect splicing of a very, very, very small number of genes, and SMN is one of the top genes where these molecules are able to produce splicing modification. Remarkably, this drug can be given by mouth and affect the life expectancy in a dose-dependent way in animals. This is a high dose, this is low dose, and this is the animals that receive no treatment. And these compounds are currently in clinical trial, and the sponsor is indicated in the bottom. And a similar idea, although with a different mechanism of action, that again, I'm not going to go into detail, was also in this very elegant paper. These are really very exciting paper to read, where another drug that achieves splicing modification of SMN2 has been identified, and with similar exciting data in the preclinical model. And the sponsor of this early clinical trial is indicated in the bottom of this line. I think that regarding gene therapy, I think different groups worldwide, really, but two groups specifically have done most of the work, one in France and one in the States. And the effort of the group that is working in the States have been taken forward now into what has been really a groundbreaking clinical trial that is currently underway. This is performed by my senior colleague Jerry Mendel from Columbus, Ohio, and who, together with Brian Casper, and the sponsor that is indicated on the bottom of the slide, have taken forward AAV gene therapy in infants with type 1 spinal muscular atrophy and 2 SMN copy number. And two different doses have been used of this AAV that is delivered intravenously by a single intravenous injection. I think that when if you forget about SMN, there are ways to also deal with the secondary pathology. One possibility is to use drugs like this oxime that appears to be targeting, has been identified because protects in vitro system neurons undergoing apoptosis, and appears to be targeting the permeability transition pores. So this is independent mechanism from SMN, and a previous randomized placebo-controlled study has been performed on this drug, and further studies are currently underway to finalize the role that this drug could have in this group of patients. And finally, if you go downstream, even downstream, and you eventually go to muscle as the ultimate area where there is weakness, this is an interesting concept as well, that is of trying to increase the sarcomere to the, if you like, to the electrical stimulus that arrive by a skeletal muscle troponin activator, and this is being pursued by one particular sponsor, and the clinical trial is currently recruiting. I think this is my last slide, and I would say, as you realize, I've remained very superficial in a way in terms of what are the outcome of many of these studies, but there is no question that there are SMN restoration strategy very well advanced. I would say that as a clinician, many of the data that have been reported, for me, indicate a very uncharacteristic for the condition improvement in functional acquisition and acquisition of gross motor milestones that we never see in this group of patients with type 1, such as sitting, standing, and in some cases, also the possibility to take steps. And I think this is, I think as a clinician, is remarkable. I think that as a clinician, I was very worried of what is the therapeutic window for type 1 SMA infants. And I'm finding that there is a therapeutic window for type 1 infants, so that I think is going to be also very interesting. And as you realize, there may be multiple ways to deal with the deficiency of the problem, even independently for SMA. And we will hear soon how successful these interventions are. This is my last slide. Thank you.
Thank you so much, Professor Muntoni, for this excellent presentation. And yes, we are interested in the science. Understanding the molecular basis for SMA is a prerequisite for strong pharmacological rationale for the drugs under investigation. So thank you very much for your presentation.
And with this, we conclude this first session. Thank you to all the speakers for their excellent presentations and for sticking to time. And we hand right over to Pavel.